Welcome you all to this comprehensive overview of antihypertensive drugs in pregnancy. This video synthesizes current research and clinical guidelines to enhance your understanding and sharpen your decision-making skills in this critical area of practice. Hypertension complicates 5 to 10% of pregnancies worldwide, positioning it as a leading contributor to maternal and perinatal morbidity and mortality. Effective management is paramount to avert severe complications such as preeclampsia, eclampsia, placental abruption, and intrauterine growth restriction. Today, we will explore the classification, pathophysiology, and therapeutic strategies, with a particular focus on antihypertensive medications and their implications. Let us begin with classification. Hypertension in pregnancy is divided into 4 distinct categories. Those are chronic hypertension, pregnancy-induced hypertension, preeclampsia, and eclampsia. Chronic hypertension refers to elevated blood pressure present before pregnancy or diagnosed prior to 20 weeks of gestation, often tied to essential hypertension or secondary causes like renal disease. Pregnancy-induced hypertension emerges after 20 weeks without proteinuria and typically resolves following delivery. Preeclampsia is marked by hypertension after 20 weeks, accompanied by proteinuria or evidence of organ damage, such as thrombocytopenia or liver dysfunction. Finally, eclampsia represents the severe progression of preeclampsia, characterized by seizures, necessitating immediate intervention. These classifications are not merely academic. They directly inform treatment thresholds and clinical approaches. Understanding the pathophysiology provides critical insight into these conditions. Chronic hypertension often stems from pre-existing vascular or endocrine disorders, requiring sustained management. In contrast, pregnancy-induced hypertension and preeclampsia arise from abnormal placentation, endothelial dysfunction, and immune activation. Preeclampsia, in particular, involves widespread vasospasm and multi-organ involvement, demanding vigilant monitoring. This foundational knowledge enables us to tailor antihypertensive therapy precisely to each condition. Management hinges on a collaborative effort, uniting obstetricians, cardiologists, and other specialists to control blood pressure while safeguarding fetal well-being. Treatment initiation varies by category. For chronic hypertension, therapy is offered when blood pressure reaches or exceeds 135/85 mm of mercury, often continuing or adjusting pre-existing regimens. In pregnancy-induced hypertension and preeclampsia, intervention begins at 140/90 mm of mercury to halt progression. Severe hypertension, defined as sustained systolic pressure of 160 or higher, or diastolic pressure of 110 or higher, demands immediate action to prevent maternal complications such as stroke or heart failure. These thresholds ensure timely, balanced care. Now, let us examine the recommended antihypertensive drugs, endorsed by authoritative bodies such as NICE, ACOG, and the World Health Organization. Labetalol, a non-selective beta blocker with alpha-1 blocking properties, stands as the first-line choice for chronic hypertension, pregnancy-induced hypertension, and preeclampsia. Initiated at 100 mg twice daily, it may be titrated up to 2,400 mg per day. It is generally safe, though fetal bradycardia warrants monitoring. Side effects include fatigue, dizziness, and nausea. Nifedipine, a calcium channel blocker that relaxes blood vessels, serves as a second-line option when labetalol is unsuitable. Dosed at 10 to 20 mg 3 times daily in immediate release form, it is safe, though brand-specific contraindications must be reviewed. Patients may experience flushing, headaches, or palpitations. Methyldopa, a centrally acting alpha-2 agonist, is a third-line agent, starting at 250 mg twice daily, up to 500 mg twice daily. It is safe but may induce maternal fatigue, depression, or hypotension. For severe hypertension, urgent options include intravenous labetalol, beginning with 20 mg over 2 minutes, oral nifedipine, administered at 10 to 20 mg every 30 minutes until controlled, and intravenous hydralazine, given at 5 to 10 mg every 20 to 30 minutes in critical care settings. These selections are grounded in robust efficacy and safety profiles, with close monitoring of maternal and fetal responses. Certain drugs, however, must be avoided due to significant risks. ACE inhibitors and angiotensin receptor blockers are contraindicated, as they are linked to fetal renal failure, oligohydramnios, and neonatal death. Discontinuation is required within 2 days of pregnancy confirmation. Thiazide diuretics pose risks of neonatal thrombocytopenia, bone marrow suppression, and electrolyte imbalances, heightening congenital abnormality concerns. Direct renin inhibitors, similarly, mirror the dangers of ACE inhibitors and lack sufficient pregnancy data, rendering them unsuitable. Avoiding these agents is non-negotiable to protect fetal health. Monitoring and follow-up are integral to effective management. Blood pressure should be checked at least weekly in pregnancy-induced hypertension, and more frequently in severe cases. Fetal growth requires ultrasound assessments every 2 to 4 weeks to detect intrauterine growth restriction. These measures enable timely therapeutic adjustments and mitigate adverse outcomes. Postnatal care remains a priority. Antihypertensive therapy may persist, tailored to blood pressure trends. For breastfeeding mothers, enalapril is recommended, with monitoring of maternal renal function and serum potassium, while diuretics and ARBs are avoided. Infants, particularly preterm ones, should be observed for blood pressure changes, drowsiness, or poor feeding in the initial weeks. This ensures safety across the postpartum transition. In conclusion, managing hypertension in pregnancy demands a nuanced strategy. Labetalol, nifedipine, and methyldopa form the therapeutic backbone, with specialized approaches for severe cases and postnatal care. Avoiding contraindicated drugs is critical, and regular monitoring underpins successful outcomes. Armed with this comprehensive knowledge, you are well equipped to navigate this complex clinical landscape with confidence. This video draws on key guidelines from NICE, ACOG, and the World Health Organization, ensuring alignment with the latest standards. Thank you for your attention, and may this foundation serve you well in your medical journey.